We have logged in.
We have 146.
I guess people
and
will...
counting.
Good afternoon, everyone. May I request panelists to please go on mute because we are having a slight echo. Thank you so much. Good afternoon, everyone, and welcome to the COVID-19 Preparedness webinar series by the Mac Institute of Healthcare Management at the Indian School of Business. I'm Soumya Seshadri, the Associate Director at the Institute and the host of the series. Today's webinar is about managing human capital and organizational sustainability in the context of crisis and beyond. In association with Equitable Healthcare Access Consortium, a platform that brings together healthcare organizations who believe in delivering care in a socially responsible manner. It is great to partner with EHAC on very interesting topics in our webinar. It is a great honor to have Dr. G N Rao, founder chair of LV Prasad Eye Institute, as our distinguished speaker today. Dr. Rao founded LVPEI after returning from the United States after a very successful career as an academic ophthalmologist. LV Prasad Eye Institute today is the biggest rural eye care network, and it is amongst the most well-known eye care. He's an institution builder, and his work has inspired several others to adopt his model of combining world-class healthcare at affordable costs to the masses. To talk to him, we have Professor Seshadri, Medical Professor of Marketing at Indian School of Business, in discussion with Dr. Rao. Professor DVR wears two hats, one as a faculty at ISB and the other as founder member and secretary of EHAC. Professor Seshadri works very closely with Dr. Rao and LVPEI. Very recently, a case study titled LV Prasad Eye Institute, Innovating the Business of Eye Care, co-authored by him, has been published at Harvard Business Publishing. And there is a book on LVPI and innovation on its way. Professor DVR teaches two courses at ISB's Advanced Management Program for Healthcare, a modular program for senior executives from healthcare delivery organizations, one on strategy of healthcare organization and another on business model innovation and entrepreneurial mindset. I now invite Arnaz Dalal, Chief Executive Officer of Equitable Healthcare Access Consortium, to introduce EHAC's work to the participants. Dr. Rao and Professor Seshadri, great pleasure having you at the webinar. Arnaz, over to you, please.
Thank you, Soumya. Good afternoon, everyone, and welcome to the next in the series of webinars co-hosted by ISB, MIHM, and EHAC. A couple of years ago, LVPEI, Arvind Eye Care Systems, Dhan Foundation, and ISB were brainstorming on the need for dialogues between established and upcoming healthcare institutions spanning various specialities to provide access to healthcare for all, irrespective of the patient's capacity to pay. It was felt that healthcare is not an isolated factor contributing to human well-being, and its connection to livelihood and education of the next generation was apparent. Thus, the idea was born to get like-minded organizations to form a network to create synergies. And this is how EHAC was born. Our core purpose is to facilitate equitable healthcare for all. Today, we are using this platform to launch our healthcare entrepreneurship mentoring program. Mentoring in healthcare for budding entrepreneurs from the right role models is very essential when the medical profession is mired in controversies about unethical practices being followed. We at EHAC are very fortunate to have these role models amongst us who are available to share their knowledge, wisdom, and precious time at no cost to well-intentioned healthcare entrepreneurs who need help on particular aspects of running their respective businesses and are not sure whom to turn to for advice. So to kickstart this program, we have Dr. G N Rao, who is the founder and chairman of LVPEI and also the chairman of EHAC. And he is in conversation with Professor V Seshadri, who is a professor of marketing at ISB and the secretary of EHAC. Dr. Rao will be sharing his views today on managing human capital and ensuring organizational sustainability. I will, if you need to know more information about us, please log on to www.ehaconsortium.org. I will now hand over the mic to Professor DVR Seshadri. DVR?
Are you able to hear me?
Yeah, we can hear you.
Okay. It's a pleasure and honor to have this discussion with Dr. Rao. It's proper and appropriate that I introduce the context properly because he is truly a stalwart in the healthcare and more particularly in ophthalmology. India has been blessed with tremendous innovation in healthcare, and that's probably because we are operating in an incredibly resource-starved environment with 90 or 95% of the people with absolutely no ability to afford any meaningful care. So two great organizations have essentially come up in the horizon of India about 30 to 45 years back. The first was Arvind Eye Care, which today is the largest, and the second is LV Prasad Eye Institute. While they both share the same core purpose of making available excellent eye care to the poorest of poor through very innovative business models. What distinguishes LVP is its idea of a pyramid model, which has taken healthcare to the most remote areas in the three captive states or target states, that is Andhra Pradesh, Telangana, and Odisha. The other very distinguishing feature of LV Prasad Eye Institute is tremendous focus on research. Both these have shown the world what is possible, and many, many other exemplars have actually taken a leaf out of this and innovated in their own ways, including Narayana Health, which is now a very, very large global organization. Dr. Rao left a very prosperous career as a star ophthalmologist from Rochester in 1996, where literally he was earning millions of dollars a year. Came back to India simply out of idealism and a statement in his mind: just because somebody is poor, they should not be denied world-class eye care. India had nothing to offer in those days. Getting a phone in 1986 would take forever, maybe 6 months, and so on. But he just sheer resilience, and today we are seeing the fruit of it. What is the USP of LV Prasad? One is, just because somebody is poor, they should not be denied world-class eye care. And there is another saying in the world of ophthalmology across the world: if LV Prasad cannot treat an eye ailment, nobody in the world can do it. And this says a lot about the phenomenal success of the organization. Dr. Rao, as he's commonly or popularly known within the institution as NAG, received the Hall of Fame award from the American Society of Cataract Refractive Surgery in 2017. And this is done by voting of 30,000 ophthalmologists across the world. So it's not an easy award to get. And right from the founding, of course, it was founded in 1999, but around right from the earliest ophthalmologists the world has known, something like 1750 and thereabouts, people have posthumously been awarded this Hall of Fame, and so far only 55 ophthalmologists across the world have received it, several of them who are long gone. He's the second Indian, the first being Dr. V, the founder of Arvind Eye Care. He's also received numerous awards from ARVO, which is the Association for Research in Vision and Ophthalmology. I'm now going to conclude this introduction because I know that Dr. Rao, we are all waiting to hear from him. And also he would be quite embarrassed if I prolong the introduction, although one can talk about him till the cows come home. What is the uniqueness of LV Prasad Eye Institute? One is The leadership starting from him is characterized by what is called level 5 leadership. That is extreme personal humility and incredible organizational ambition. Then a laser-like focus on research, because the belief is the world keeps coming up with new eye diseases, new conditions, and so on. And therefore, research is vital to treat the very, very difficult and new to the world and difficult eye care diseases. Of course, for a lay visitor like me, you will be astounded by the greenery, because Dr. Rao felt at that time, and that is continued to the next generation of leaders, that a hospital should not look like a hospital. It should have greenery and pleasantness in the whole environment. The culture is very unique and egalitarian. You will see the top leaders actually dining with somebody who is cleaning the floor or somebody who is an electrician, and there's no qualms about it. The person who eats, including the chairman, picks up his plate, cleans the table, and drops the plate in the assigned place. Why is this talk important? I think it's very important because the world is reeling under COVID. And of course, we all expect we'll come out of it soon. So everybody is grappling with how do we, whichever organization, it could be Ashok Leyland, it could be Birla, Aditya Birla Group, it could be Apollo Group, whatever, it doesn't matter. Everybody is saying, how do we come back to some semblance of normalcy after these 2 torrid months where the tsunami has hit every human being on earth, 7 billion people. And of course, millions of organizations have been adversely affected. There are new organizations in startup healthcare space, which can pretty well, say, okay, friends, 30 employees, you may please take a walk and find something because we just can't afford to pay salaries. Goodies Sudhakar says there is a problem of audio. Can somebody fix it? Okay. And then there are established organizations, like the Tata Group and many others who have been around for a long time. And Arvind and LV have been around for a very long time. What's important is these established organizations have expectations from stakeholders. They can't just wish away and, fold the tent. There is a huge amount of cultural way of doing things. There are processes established, and you can't just take a U-turn suddenly. And therefore, it's going to be very, very challenging of how do you bring back a semblance of normalcy? How did you keep semblance of normalcy during this crisis and so on? So there can't be a better person than Dr. Rao to reflect on the journey of LVP and how they managed the last 2 or 2.5 months. And of course, one is not clear how long this fog will last, but let's say another 1 month from an optimistic perspective. And thereafter what? So this is where I'll end my longish introduction, but I think this was essential. Soumya, you might want to take a quick poll on whether people can hear. I'm getting a couple of messages about not hearing. Okay.
Thank you, sir. We can hear you clearly. Mostly we bandwidth issues at their end, so they should try and see
Good. Okay, friends, I'm going to keep the discussion to about 35 minutes with Dr. Rao so that we have at least half an hour to 40 or 45 minutes in terms of Q&A from the audience. So I'll be very rigorous in my timing. And I'm just going to walk through 4 themes which are absolutely, vital for any organization, irrespective of whether it's eye care or healthcare or airline or hotel or manufacturing, whatever. The first is, how do you lead through crisis? And also, how do you keep employee engagement, especially when the morale is drooping? The second one is organizational sustainability. How do you keep the organization sustainable, financially and every which way? And what are the trade-offs and dilemmas in decision making? The third one is redefinition of eye care delivery models. Obviously, LV has been a major innovator in eye care delivery, but does Dr. Rao and the top management of LV see a major change of course? Will their business models change? And the fourth is implications of non-accessibility of eye care to the vulnerable population and possible solutions. So these are the broad themes. And then there is a closing section on advice to, healthcare organizations and broadly other organizations. So without further ado, I'll keep my questioning somewhat brief, but they will hover around these 5 topics in sequence, and I'll be pretty clear about the timing, roughly about 5 to 6 minutes for Dr. Rao to reflect on each theme. Dr. Rao, the first one is, what processes have been put in LV Prasad Eye Institute ever since the lockdown has happened to address emergencies as well as elective surgeries? What are your views on work from home in the context of healthcare? Is this sustainable? What has been LV's experience on this? And what processes have been put in place to allay the fears of employees? Obviously, this is a basket full, and I'm sure you can talk on each of them for half an hour or 1 hour. But you can pick and choose and focus on only things that will fit into a time frame of about 6 or 5 minutes. Over to you, sir. And I'll put my speaker on mute.
One thing that I've been thinking is the measure since the development of this crisis, how do they align with the values we go by at LV Prasad? We have a set of 5 values: excellence, equity, patient first, togetherness, and integrity. So the first thing that we wanted to do was to make sure, in a very equitable manner, each one of our employees, each one in our team, of all cadres, are given the assurance that their jobs are secure and their monthly income is secure. So that communication was sent out. Since we also believe in equity, it should not be limited to only our own people. We also made sure that we do not delay any of our vendor payments during this time. The third also is anybody who offered to waive the payments at this time and allowing us delayed payment even there, we respectfully declined and wanted to clear the payments because we wanted to start with a clean slate. In all this, important thing is, unless we have a team that's very strong, that is committed, we could have never reached the stage we are in today. And for each member of that team, we owe a debt. And this kind of assurance of their security, financial security, is a repayment that the Institute can make for their long years of commitment. The second is the patient safety. We did not want anybody coming to us, either the patients or the visitors or the attendants of the patients, to have any risk of exposure to this new plague that we are encountering. Because we really don't know how to treat the problem should somebody develop the problem. So we immediately started putting in place all the steps that are required to make sure that no patient is unnecessarily exposed to this risk. So we limited our services to just emergency care, and for those who require some kind of follow-up care because of the particular eye problem, we started enhancing our teleconsultation services. We were doing this to a limited extent in the past, but this opportunity actually allowed us to enhance our ability to use teleophthalmology services and to reach out to patients and provide the necessary care. And the third thing that we did was to make sure that communications are sent to each one of our patients through all kinds of communication channels. One is about their own condition and how we can help them. Second also is to give them some kind of an education about preventive measures against COVID-19. What is very heartening is what happened in our rural network. Our colleagues in our secondary and primary care centers in the remote rural areas of 3 states have begun to call each of our patients over the past many years and asking them about the status of their health, their family's health, and then whether they need any kind of help beyond eye care. And one thing that they did, very, very exemplary, is many of the secondary center staff have pooled some resources on their own voluntarily and supported some poor families in the areas where these secondary centers are located. I did not tell them to do it. Nobody told them to do it. They on their own have done that, and very commendable. This is how that clearly shows that we are part of the community. We are not just an eye care center. We are part of the community. We are there to be with them, to share all the good and bad with that community. The other one is working from home. I think while in medical care, working from home has limitations. To some extent it worked. Many of our colleagues have used the time to sharpen their other skills or increase their productivity in other areas. You are alluding to our interest in research. I think across the network, a lot of our faculty, almost all of them, have either started producing more manuscripts out of their work or begun to produce manuscripts if they did not do it in the past. This was an opportunity and a very welcome development from our institute perspective. And another area that has taken a big boost because of this available time of our faculty is our education. Nearly 500 world-class lectures were prepared by our faculty during this time, which will be made available to the entire world very soon. The team of education led by Avinash Pathagat did a remarkable job in being very innovative and continue to do this. In addition to in-house educational programs for all cadres of our staff. So that's what it is. That has happened in the past 6 to 8 weeks. I'll stop with this question that I think I completed my 5 minutes.
Thank you, Dr. Rao, for extremely comprehensive response to this very important question of leading through crisis and employee engagement. If in one sentence I need to capture what you said, rather than collapse under the weight of the crisis and the burdens, how do you see opportunity in adversity is beautifully brought out, and that is going to take LV to the next trajectory simply because your research output and learning output has been prolific in these 2 months. Hats off to you. The second one is organizational sustainability and trade-offs and dilemmas in decision making. Given that you're a non-profit organization, and even for for-profit organizations which are profligate, the reserves would not be too much. And in your case and in other non-profit organizations, I'm not even sure, and we don't have to even enter into that realm about talking about how much reserves. But nevertheless, what have you done to address the organizational sustainability? On the human side, we have looked at it, addressing stakeholders, we have looked at it, but I'm focusing on financial sustainability. Obviously, the research focus needs a lot of financial resources to trigger them. And what happens to LVPEI's key differentiator of research going forward? And how did LVP tweak its budgeting process in such incredibly uncertain times?
I've been very fortunate all my life to get education from a variety of people and a variety of organizations. One thing I learned is from an organization I was closely associated with for some years called International Agency for Prevention of Blindness. When I was working in that, it was based out of London. I came to know of what kind of reserves a not-for-profit organization should have. And according to British law, that is a maximum of 6 months of equivalent of operating expenses. And based on that and based on our circumstances, our entire management team has always aspired to keep a reserve equivalent to between 6 to 12 months of our operating expenses should everything collapse. Not even in my wildest dreams did I think that everything would collapse in a medical care organization. I thought even if all the grants and donations stop, our patient care will always go on. But we never anticipated even the patient care revenue would collapse the way it did. But I think by following that advice, by following that learning, by building that reserve over the past some years, it is now helping us to tide over the crisis. The second thing is, since the inception, although many people have the impression that LVP is dependent a lot on the donations. In fact, since the 4th month of our inception, we have never been in the red for operating expenses just from the revenue that we generated from our paying patients. We have been very careful, almost like a middle class mentality. Never spend what you don't have. So we kept assiduously to that rule that for all operating expenses, we will only depend on the money we earn. We will not depend on the vulnerable resources like grants and donations. And that philosophy has again helped us at this time. And going forwards, research, you were asking, how is it funded? Our research funding has 3 components all along. The capital was all funded by philanthropy. The operating expenses for actual conducting of research was through competitive research grants. And for the salaries of the scientists, which Indian granting agencies don't support, the institute supported from its internal resources. I'm optimistic that even going into the future, we might not have any significant difficulty to carry this, following the same philosophy. And in terms of offsetting the revenue losses that we might incur from some sources, I think we are now having some new areas of possible revenue generation. One is the technology innovation component that we have begun about 6-7 years ago. While till date we haven't been a big revenue generating stream from there, but its innovations have been very, very rewarding. Like for example, in this COVID crisis, a simple visor was immediately developed by one of our young engineers. And that has helped thousands of people all over the world in many organizations, both in Hyderabad, outside Hyderabad, in India, and South Africa. We put it as an open source innovation. Similarly, our electronic medical record system is gaining significant traction now. And many organizations from around the world are seeking that kind of a system. Maybe there is an opportunity there because we have never looked at commercializing many of our things that we are sitting on. Maybe this is the time that we should begin to look at. These are some examples. Similarly, some of the innovations in our biology, the stem cell, the artificial cornea, those kinds of innovations may provide us some opportunities. We have an engineering group. We have some contact lens manufacturing group. These groups may bring in additional revenues, and that may offset whatever losses we might incur in other areas. And that should take care of the any possible deficits in some areas that we have been traditionally there. I think this is how we want to move on.
Thank you, Dr. Rao. It was brilliant that basically two things that I picked up. One is that you have a very frugal approach even in the best of times, and you sort of stash away for a rainy day. And in your case, the war chest is about an year one can last. Hopefully, all this current crisis will end in less than a month. That's what the world is anticipating. The second is to have parallel revenue streams that are ready, and you can trigger them at short notice. And in your case, it is innovation, education, EMR, and so on. So I think there is no gainsay but to say that organizations which are constantly looking at what is the next big thing and innovating are the ones who are going to win going forward. Now I'd like to switch to the third theme, which is redefinition of eye care delivery models. What is the impact of secondary and centers and vision centers, which have been unique part of the LVP pyramid model? What is your plan as you come out of the lockdown to not just stabilize operations, but also grow and in many cases change the way the operations function, especially in the community eye care arena?
I think our opportunities all of a sudden have become better. Because we set up the network only with the idea of touching the lives of those people who are most neglected in our communities. And today that's going to help us because we are there with a permanent infrastructure to people who need it most. No longer can the eye camps work. The eye camp will now become a thing of the past. You need permanent facilities in remote rural areas to provide eye care. I'm happy that we already have them in the rural areas, both the primary centers and secondary centers. Our expectation is that the demand for care in these centers will increase in the current situation because nobody would like to travel for too long, too far, and to get their care. So our primary centers are within 10-12 kilometer radius of everybody. And our secondary centers are within 50 to 75 kilometers of everybody where we intend to provide service. With that kind of a system, we believe our rural eye care network will become busier post-COVID. And the community engagement that we already have and the community support that we already have in most of these communities will be a big ally for us in weathering this storm. So this is definitely the way forward for reaching out to the vulnerable populations is to develop permanent facilities in rural areas. I hope the government will wake up and the government will establish more and more such facilities throughout the country. We need a lot of them. It doesn't have to be eye care in isolation, and eye care can be an integral part of general health centers. And we need many more such functioning, high-quality, comprehensive health centers throughout the rural areas. Because people will not travel to big cities in large numbers in the future for small problems. Because of all the constraints that at least we are anticipating as of today because of the crisis like COVID. And people say we may be in for even more pandemics in the future. I can't hear you.
Yeah, sorry. So people will be hesitant to go to the big cities for treatment because they're afraid they'll catch the pandemic, and also because of governmental restrictions on free movement of people. That's what I hear you say.
Both. I think they don't want to go too far. The second is it's going to be difficult, and then there will be increasing restrictions.
Okay. So to that extent, friends, I just want to comment here that about 30 years back, or maybe a little less than that, although LVP has been around for 34 years, the pyramid structuring of LV Prasad Eye Institute has ensured that there would be physical facilities which are not mobile but permanent in the remotest corners of the states where it operates. And therefore, what I hear Dr. Rao say is that because of the reduced movement of people, they will not be going here and there, and therefore there's going to be a huge upsurge of requirement from patients to visit their centers which are at the grassroots level. But this brings us to the very next and last major theme, the implications of non-accessibility of eye care to the vulnerable population and possible solutions. You've already addressed that, saying that your permanent facilities are going to ensure that people visit them. But related to that is another question. Once you have a surge in patients at that socioeconomic strata who can't pay, the whole model hinges upon cross-subsidization. So what will happen to LVP's cross-subsidization policy going forward? How will the rehab subspecialty get reinvented? Because rehab requires, you have at your tertiary hospitals and to a lesser extent in secondary hospitals, but it requires face-to-face or very close contact between, on a regular basis, rehabilitation of, let's say, blind children. How do they come back to reasonably to the mainstream? So while LVP does not conduct eye camps, what is the future of eye camps? You've already addressed, saying that eye camps are a thing of the past. But these two questions of how the cross-subsidization will get impacted and also the rehab and how that is going to get reinvented would be of great value to us.
Rehab, I must say, we're very fortunate to have one of the most dedicated rehabilitation teams anywhere. For the past 8 weeks, the incredible work that they did using technology and supporting all our clients with various kinds of disabilities in addition to blindness is an incredible example of what commitment can achieve. They already have all systems in place on how to take care of these people with visual disabilities without them being here in our institute physically. So that models are already developed. So that will be, I think, extended, and more clients will be offered services without being present with us in any of our centers. So there I think we are all set. In terms of how do we support the vulnerable? As of now, I don't see any significant difference. We have been treating people who paid nothing to us in our rural centers. The non-paying surgeries amount to average of 65 to 70% over the years. And that will continue. And we will continue to treat them. And at our primary centers, 100% of the care is free anyway. So at least in our institute, there would be not too much difference in dealing with those populations. And I'm sure with more of telemedicine, more of technological innovations, we'll get even deeper into these communities. We probably will be continuing to innovate as to how to target each 1,000 population, a cluster of 1,000 people. From that point on, how do we take care of everybody in the remote rural areas where we have our presence? A lot of innovations will continue to happen. We are again very privileged to have a incredibly committed community eye health team, and they constantly are looking for ways of reaching out to most people and providing the best quality service. So at least in our case, I'm not anticipating any difficulty to provide services to the vulnerable population, but for others who want to continue to provide, they have to begin to think of, should there be no funding from anybody? How do we provide services to these people is something that is a big question. Maybe this is the time again, everybody is looking for government to support everything. I don't know how far the government can support the circumstances of the economy today. But there will be a large dependence on the governmental funding by many organizations to continue the service to the vulnerable populations across the country. Because there are a lot of organizations even today depend on the subsidies that are provided by the government for the eye care services, other healthcare services. So that kind of dependence will continue. The government has to do something. I hope this pandemic will bring about a completely different way of thinking within the government of how to allocate the budget. I think healthcare right now should be allocated as much proportion of the budget as defense. Because no war could have killed so many people as this pandemic has the potential to. So if we are spending so much money on defense, most of these weapons are always unused most of the time. Why can't we create a healthcare system with adequate funding that will protect the health of everybody within our country? I think that kind of thing should come, and even within the corporate sector and the philanthropic sector, I hope more and more people will give more and more money to healthcare in the country. These kinds of approaches only can help the vulnerable population to make sure that we provide appropriate health for them.
Thank you, Dr. Rao. Now, summarize what you've said in the last few minutes. First is LVP is in a very good wicket because you have never depended on government, and maybe that has now come as a huge advantage because the government is going forward going to have too many mouths to feed, and it's just question of trying to do some optimization. But the government, on the one side, revenues are dipping hugely, at least in the short run, and then everybody is going to go and queue up before the government. The second thing I hear you say is that you're leveraging technology to the hilt. For example, in the rehab area of remotely providing those services, leveraging technology. The third thing, which I think is underlying what you say, is while the primary and the poor people coming to your primary and secondary centers, vision centers, is going to increase, there's also going to be enough paying patients so that the delicate balance that you have been treading will not be greatly disturbed. So with this, I'd like to come to the conclusion, which is some parting advice to healthcare organizations on how to cope with the current crisis and such crisis, which, as you also said, these pandemics will keep showing their ugly head. I think you have more or less answered that, but if you'd like to give one or two takeaways concrete for them, apart from whatever has been said, that will be nice. What is the future of eye care in the medium term of 1 or 2 to 3 years? And probably my question itself has the answer. Eye care will not vanish in a hurry. Everybody who has 2 eyes will need eye care at some point or the other. But the last and important question for you is, going forward, which healthcare specialties will gain and which will find the going tough in the medium term of 1 to 3 years?
In general, I believe eye care will go through some tough time in the immediate future. There will be some pain. Some organizations will suffer. some solo practitioner regretfully may have problems. And what is more worrying is the younger generation that's just coming out of training programs may find it tough to find suitable opportunities to work. So this is going to be there for the next few years. Of course, the duration depends on the impact of COVID. Is it going to last with us for 6 months, 1 year, multiple years? We don't know. It depends on that. But definitely ophthalmology and eye care will have some pain. Along with ophthalmology, I hear even from friends in the US, some of the people who came out of training are already desperate to get jobs in the US in ophthalmology. So this kind of thing will be there. Along with ophthalmology, maybe branches like dentistry, ENT, and some of those may have problems. The ones that will be in great demand would be obviously internal medicine, its various subspecialties, and intensive care, emergency medicine. These are the kinds of branches that will be in great demand. And one thing that has always been neglected by the entire medical profession, and it's about time for them to wake up, is the area of public health. For the first time I saw everybody has some understanding of the importance of public, including lay public. And more medical professionals, I hope, will get into the area of public health. And that will have a huge opportunities in future. So, of course, another area, some medical professionals should think a little outside the box. They should begin to think of areas of innovation, technology innovation, biologic innovation. Some of the medical professionals should think of getting into serious basic research. Look at the opportunity today for vaccine development and those kinds of things. And drugs for problems like COVID. All these opportunities are there. I think people should begin to look at new potential areas of opportunity in future instead of the customary and traditional clinical specialties that in India we have been following all these years.
Excellent. So thank you, Dr. Rao. This brings us essentially to the end of our discussion, and I'll quickly hand over to Soumya. But before that, I want to summarize the last segment that unless the days of individual practitioners might take a little bit of beating, and those diseases and health conditions that have something to do with the head, where all the COVID breathing and all that happens, ENT, possibly eye care, of course, and then dentistry and cosmetic surgery of some kind to sort of enhance my looks. All those might take a beating, but there are many others, including emergency medicine and internal medicine, and so many other specialties which willy-nilly people will have no option but to queue up for healthcare providers. This brings us to the essential
One sentence. I think one thing for sure, medical professionals should be ready to accept lower remuneration in the immediate future. The incomes will not be as good as they were pre-COVID for some time to come.
That's a brilliant observation. If people are willing to come down on the remunerations and hospitals willing to come down on their profitabilities, the whole situation can change, because people are people and they have so many diseases and they need to be cured. What's probably a barrier is the high costs, and then many of them can be postponed or whatever. So to that extent, if there is a repricing that happens, it will be a very big opportunity. I think some early exemplars have to show the way, and then the rest of the world will fall in place. Thank you for a very fascinating reflections. I think these are absolutely precious, coming from about 60 years of your own, 50 years life experiences in running top-notch medical facilities, especially in ophthalmology. So over to Soumya to take over. I'm putting my mic on mute, Soumya.
Thank you very much, Professor DVR. Thank you so much, Dr. Rao, for talking about your philosophy and how that can be translated to some of the other clinical organizations and professionals. We will now take questions from participants. Please send in your questions in the Q&A box and not in the chat box. While we are receiving questions, I have 2 or 3 questions which has already come in, and I'm going to direct those to Dr. Rao. This is with reference to the already existing model, that is, since minimal spread of COVID in rural and there is minimal spread of coronavirus in rural India, how wise is it to defer eye camps forever with innovations, as we should find ways to address this vulnerable group that comprises 40% of total cataract volume in the country? So, Dr. Rao, it will be good to take your views on that.
I'm sorry, you had to repeat that question. I was not clear.
So I think this is in response to some of the points you talked about, eye camps and things in the rural area may be difficult. So the question is, since there is minimum COVID in the rural area, is it viable to go ahead with rural treatment even in this context? Is there any innovations that can help promote these kind of treatment delivery?
I think I am always a believer. I think we have already, in addition to, we are not just talking about LV Prasad. In rural areas, there are many, many facilities for eye care throughout the country. We have to first optimally utilize every single eye center or eye practice that is available in rural areas. You cannot, anyway, we have not been operating in the eye camps for the past many years now. But you cannot now even do screening camps very effectively because people will be afraid. You cannot bus the people from the rural areas into a urban center and operate in urban center and send them back. That will not happen in the near future. So that's why you will have to either establish your own rural centers, or you can work with the existing rural centers and make them better and utilize them optimally. Or the government should begin to really empower and make their rural facilities much better, both in terms of infrastructure as well as the kind of human resources that they have with appropriate training to each of them. If you have that combination, I think you can tackle the problem. Can we operate today in the rural areas? Yes, we can, but not without taking the same precautions that we take in an urban center. Whether it's a rural area with a low number of corona cases today or an urban area with a high number, we don't know what is lurking where. Not knowing exactly what the picture is, we can't take any chance even in the rural area. Even there, when you begin to operate, you have to take the same precautions.
Thank you. The next question is about how LVPEI has reconfigured the emergency room, since that is a service that continues to be provided due to its nature.
Yeah, I think what we did is our staff is vertically divided into 3 groups. From the ophthalmologist to all the cadres, all the way down. And each of them were asked to work for 2 days a week. And one group doesn't mingle with the other group. And then in terms of process and procedure, all the way from the entrance gate to the patient care entrance to the triaging to the area where you actually check in to everything, every stage, all the precautions are taken and all the infrastructure is set up to ensure social distancing, personal hygiene, and making sure everybody is protected. Every patient and the accompanying person should have a mask. Their hands are sanitized before they are allowed in, and the temperature is checked at the entrance. So all these precautions are taken. And each member of our staff throughout our network is provided appropriate protective gear, from mask and visor to different types of PPE depending on which area they are working. So that's how we did it.
Thank you. So there are two major streams of questions coming up, as I can see here, one on innovation and the other on technology. So I'll first take the one on innovation. So there are few participants who want to understand the direction in which innovation is heading in healthcare delivery, particularly in ophthalmology. In the next 5 to 10 years, opportunities in nanotechnology or AI-based drug discovery, brain-computer interfacing, etc. These are some of the trends in the innovation-related questions.
Yeah, well, these are all obviously very exciting areas of research and innovation. And everything, even in the pre-COVID era, a lot of work has been done and it will continue to be done. But I think now there should be an acceleration in some select areas which might benefit the immediate need, which might meet the demand that we will have in the immediate need. That has to be identified by each group. What is it that we need now? And of all the innovations that are possible, where do we focus on? And once you identify that, you have to run with them. That's how I would do it. The opportunities in the area of technology, in the area of biology, in the area of pharmacology, in the area of microbiology, so multiple areas. In all these areas, I think this is how we should do it. We have to first identify what is the most important area that we want to go. Otherwise, a huge opportunity in so many areas. AI. We have been hearing AI for the past nearly a decade or so. And I think now is the time to really put it to test and see how much of AI will give us the right kind of benefit.
Thank you, Dr. Rao. The other stream of questions are directed towards use of technology for healthcare delivery. For example, how is telemedicine helping care of the eye care and how that can be strengthened? And also other technologies like app-based technology for treatment of eye care. Over to you, sir.
Yeah, let me admit I'm not a great expert on technology. I only know marginally a little bit. But from what we do, we use a variety of technologies for telemedicine. One is a simple tablet-based one that we have in our rural centers that is connected to our tertiary center. And at the telemedicine center here, people take care of those cases. And the second is where you could use some of the more sophisticated cameras and take pictures and then send it to the next level to the specialists and get their advantage or advice. And that's the second one. And the third one is all the way from the field level to the primary to the secondary level, we have our electronic medical record system that is linked. And through that also you can get a lot of information and advice to patients. One thing that can be done is to perhaps use some of the paramedical people to go to the patient's homes and maybe they can give the feedback of information on the status of the patient, or the patients themselves can take pictures of their eyes and sent to the doctors, and to some degree that can help. But these are all very, to me, there is a lot of noise in telemedicine. These have to be simplified, and we have to come up with 3, 4 very highly functional systems of teleophthalmology and telemedicine that can be managed easily by every practicing doctor. And that, I think, is a big opportunity, and I think those will come now. And many doctors will benefit from such technologies.
So we have a few questions about opportunities for some charitable hospitals and such who are basically primarily located in urban centers, if they can reach out to LVPEI for some technical support in establishing secondary centers and vision centers.
Yeah, we'll be happy to help. We have helped many organizations throughout the past 25 years in setting up their secondary and primary care vision centers, and I will be happy to help.
All right. Thank you so much. In the interest of time, I would like to close the session. We would have liked to answer every single question, but I've tried to scan through and see what are the major trends in the questions and then try to articulate it to Dr. Rao. Dr. Rao, thank you so much for your time. Professor DVR, so much for your time in curating this interesting conversation. Before we sign off, Dr. Rao, can you please just give like a 2-minute advice to all of us who are like going through this very difficult times, and what is it that you really want us to take home and ponder about?
I think both the vaccine and the treatment for the problem are not going to be immediate. Looks like several months. So the only remedy that we have available to us is the preventive measures. So we should follow the advice of the experts, like personal hygiene, social distancing, all these I think we have to maintain. Whatever task we are doing, are we going to shut ourselves inside our homes? Probably no, we can't. We have to get out and get on with our lives. While at the same time following all these principles, we should not violate these preventive measures even when we begin to get on with our regular life. So that's all I can tell, and I think more and more information is coming every day. We still are in the dark about the end point of the current crisis. That's why we have to be constantly vigilant about the risk that is lurking around and take all the preventive measures.
Dr. Rao, if I may just intervene here, it has been a very, very fascinating session, and I know that you're a stickler for time. We started on time and we are ending on time. It is a lot of thought for food for thought. We're going to write this up as a blog, as an article, and hopefully in the mainstream media as well. And for those who have questions but not been answered because there are so many questions, you can go to our EHAC website, ehaconsortium.org, and there you will find a link to Arnaz Dalal. She's the CEO, and if you can post to her, every question will be answered. We'll try to group those questions. If necessary, we will request Dr. Rao's expertise to address some of the more difficult questions that are beyond us. So with this, on my own behalf, Dr. Rao, and on behalf of ISB, Max Institute of Healthcare, as well as EHAC, we'd like to sincerely thank you. What we have seen in the last 1 hour is absolutely fascinating. A lot of food for thought, even for people like me who are essentially dabbling in the healthcare space. New avenues for us to do some research from a management perspective and so on. So once again, deep gratitude to you for sharing your perspectives. I'll now hand over to Soumya for a final word of
Thanks for giving me the pleasure.
Thank you very much. And everyone, please stay safe and stay connected with us. I'm just going to our contact details on screen in case you want to get in touch with the HAC or the healthcare activities at ISB. The recordings of all the webinars will be put up on our LinkedIn page, Healthcare at ISB. Please look it up there. Follow us so that you can get some updates in real time. And our next webinar is going to be in the stream of health tech and innovation. We talked about innovating during crisis, and now we are going to go to the next level and see what it takes to take ideas to market. We're going to do this discussion in association with Tai Chandigarh. We have a venture capitalist, a startup which has kind of done a little bit of a lot of headway in the healthcare sector at this point, Doxper. Shailesh, the promoter, is going to be part of the discussion, and we have another hospital, typically a buyer with the whole country going to actually use the product. So this is going to be the context of the discussion. Look forward to seeing you all in our next webinar, and thank you so much for all your participation. Thank you, Arnas, for your participation.
Thank you everybody. Thank you, Dr. Rao, Divya, and Soumya.